Hello everyone, and after a long time, I'm taking this lecture, and we are starting with general pharmacology. And in general pharmacology, our first topic is absorption. So we'll primarily discuss about absorption today. But first of all, let's understand the basic. What is the meaning of pharmacokinetics and pharmacodynamics? Right. So I'm just taking you into a basic outline of what is pharmacology. So pharmacology is a study of drugs and how we are using the drugs in diagnosing a condition or in the management, in the treatment, or in the research purposes. What is the which we are using the drugs? We have to read, and this subject requires a lot of memorization also. But most importantly, concepts are very important. So I'll be here to give you the core concepts of pharmacology, and starting with general pharmacology. So in general pharmacology, we have to learn pharmacokinetics, something called as a pharmacokinetics, pharmacodynamics, and thirdly, some clinical trials and miscellaneous concepts. I tell them, right? So these three things we have to read, where pharmacokinetics is the most conceptual part. Pharmacodynamics is concepts are there. It is an interesting part as compared to pharmacokinetics. Pharmacokinetics will feel a bit dry to read, and these miscellaneous parts are basically which you have to know in medical practice. What is an OTG drug? What is the schedules which are given for classification of drugs? Right? What is an adverse drug reaction? We'll see in subsequent classes. Right? So let's start with the pharmacokinetics, and in pharmacokinetics we have to read. So let's give the heading. Please make notes with me. Pharmacokinetics. So, what our body is doing to a drug is called as pharmacokinetics, and what the drug is doing to our body is called as pharmacodynamics. Okay. So, first line is that what our body is doing to a drug. What our body is doing to a drug is called pharmacokinetics. So, you know the meaning of this term kinetics. In lower classes, you must have read that this kinetics basically means movement. So, how a drug is basically moving inside the body and what our body is doing to that drug is called as pharmacokinetics. And dynamics means effects basically. You must have read dynamics, Newton's law of motion, which is a basic application of dynamics in physics. And in dynamics, here means the effects produced by the drug on our body. Okay, how the drug is attaching to a receptor, what are the different types of receptors, and what is the concept of inhibition, what is the concept of activation, how the graphs we are plotting, the dose response curves, this all come under pharmacodynamics. And in under pharmacokinetics, we are basically gonna read about four concepts. In pharmacokinetics, it is called as an ADME study. ADME study. So what is an ADME study? So A stands for absorption, D stands for distribution, M stands for metabolism, and E stands for excretion. So a drug is being absorbed. So let's say this is a drug. This is a tablet which you ingested. Let's say it is absorbed in the stomach. Here absorption occurred, right? And from stomach it went to the blood vessel. Let me draw the blood vessel in red. Via the blood vessel it enters the systemic circulation, that it moves to the heart. From the heart it goes via the ventricles, pump blood. From the blood the drug is dissolved in the blood, so it moves like this, and it is called as a distribution. Basically the drug is being distributed and it goes to the liver where metabolism occurs. know that the liver is the main site of metabolism. Liver is the main site of metabolism. And here a metabolism occurs, which is called the fast path metabolism. I'll give you an overview here. Basically, whatever drug you ingest, let's say you ingested 100. I'm just arbitrarily taking a number 100. So liver eats up or liver consumes, let's say 40% of it. Let's say liver consumes 40% of it. Let's say liver consumes 40%. So this 40% consumed part is basically not moving into the excretion, right? So whatever drug is basically available to the cells of the body after metabolism is called as the bioavailability. Okay. 60 will be the bioavailability because 40 is eaten up by which metabolism? This is called as the first pass metabolism. We'll learn about first pass metabolism in subsequent part, in subsequent, let's say, this lecture or in the next lecture, right? Okay. So that's about the metabolism, and that's about the whole overview of your pharmacokinetics, right? Here we have something called as the primary pharmacokinetic parameters. Primary pharmacokinetic parameters. So what are this? We have three parameters. One is called as the BA, that is bioavailability. One is called as the BD, that is called volume of distribution. And one is called the CL, that is the clearance. Done? Okay. So these are the three pharmacokinetic parameters: bioavailability, BD, and CL. We have separate sections on what is BA, what is BD, and what is CL, which we'll see in subsequent parts of this lecture, right? Not subsequent parts of this lecture. Basically, this BA will discuss in here. BD will be discussed in the distribution part. CL will discuss in the excretion part, right? Understood? So here I am just giving an overview what is BA. After metabolism, whatever drug is available for use in the body is called the bioavailability. Volume of distribution is the apparent volume of what is being absorbed. Okay, well, it is a big concept, so I'm not going into much detail. Clearance is basically how much is cleared off. Okay, the drug. So these three are the primary pharmacokinetic parameters. Except this, all parameters like many other parameters are there, like loading dose. For the first dose, okay, the start, the push. Let's say we have a car here, and we have to start the car. So the push button, okay, the higher dose which you have to give first, it's called the loading dose. Afterwards, we'll give smaller doses because we don't require that. So the subsequent doses are called the maintenance dose, right? Loading dose, maintenance dose. What is the T half of the drug? All these are called the secondary pharmacokinetic parameters. All are the secondary pharmacokinetic parameters, right? So that was our basic concept. That was our warm up. Let's start with our main topic, that is absorption of a drug. Okay, absorption. Absorption. So what is absorption? Absorption basically refers to how the drug is moving inside the cells of the body, right? How they're crossing. What is the route of administration? We have the three important things we'll discuss. First of all, how a drug is crossing a cell. Let's say this is a cell and a drug D has to cross inside the cell. How it is basically crossing, right? This is called as an absorption. So let's learn what are the different ways in which this can cross, right? So the very first way which you have read in your lower classes is called the simple diffusion. Simple diffusion. Do I need to tell you what is simple diffusion? Or you have read in your physiology? Okay. So basically, simple or passive diffusion is the most accepted, don't say most accepted, it is used by most of the drugs basically. Okay. So most drugs use this route. Simple diffusion occurs from the higher concentration to lower concentration. You all know this. It doesn't require ATP. It is basically a concentration dependent process, right? Just diffusion occurred, right? Low concentration to high concentration. What is the catch here? Basically, this simple diffusion can be only used if the drug is lipid soluble. Only used if it is a lipid soluble drug. Why? Because the cell membrane is composed of lipids. If the drug is lipid soluble, it can simply diffuse. If the drug is not lipid soluble, it can diffuse. Okay, simply, right? And also, just know that only the drugs which have a size of let's say not size, molecular weight of less than 100 kilodalton, okay, less than 100 kDa, this can only diffuse, right? This can only diffuse simply. Understood? This uh, this our you can say simple diffusion. So what are the lipid soluble drugs? All the corticosteroids, right? All the drugs which have a lipid component in that, all the prednisolone, your all the corticosteroids, right? You can just state that testosterone, estrogen, all that. Yeah, simple diffusion is done. Second one is called as the aqueous diffusion. Aqueous diffusion. Aqueous diffusion is basically the diffusion which is occurring due to this blue channels which I'm drawing here, and these blue channels are what are called as the aquaporins. I'm sure you have heard this name before. Aquaporin 1, Aquaporin 2, Aquaporin 5. Okay, must have heard. So what is this? No ATP required. Along the concentration gradient, just the drug goes via the aquaporins. This is the drug, it went via the aquaporins. No ATP required. Along the gradient, right? No ATP required along the gradient. And what is the drug we have to remember? Lithium. Example is lithium, which is moving via aqueous diffusion. Done? Okay. Now the third route which you have to remember is called the endocytosis. It's called as the endocytosis. What is this? You have heard, right? So this is called the cell eating or cell drinking. Cell eating or cell drinking. Cell eating is called the phagocytosis. Cell drinking is called the pinocytosis. Understood? So wherever a drug is basically engulfed by invagination in the membrane, right? So let's say this is a cell, and a drug comes. So the drug is basically taken inside by this indentation created in the membrane. This moves inside, causing a phagosome formation. So this is the phagosome formation. The drug comes inside. Sorry. Understood? So you just imagine what drugs will use this. All the large proteinaceous drugs, right? All the drugs which are basically the protein structure is there, there's a large, right? So large proteins use this. Can you give an example? Yes. Toxins, botulinum toxin. I'm writing botox is a brand name basically. So botulinum toxin. Botulinum toxin is basically the fillers which you inject over the face here, and the celebrities they use for creating an anti-aging effect, right? It makes the skin taut. So we'll read about botulinum toxin when we read to ANS, right? So botulinum toxin is basically going inside the cell by this pinocytosis, and a vitamin, basically vitamin B12 is also going inside the cell by this process of endocytosis. Understood? Okay. Now we have to see a process called as the filtration. Filtration or parasitosis, which you have to tell, but parasitosis term is not commonly used. I'm writing the term filtration. Filtration. So what is this process? So the drug basically moves between the cells. Okay. So let's say this is a cell. Let's say this is a cell, and the drug is basically moving between the cells. So this is the drug, and it is moving between the cells. And what type of cells? What type of drugs can use this? So we have a very important example: subcutaneous insulin injection. The example is your subcutaneous insulin injection. So we'll learn about insulin when we move to endocrine chapter. Okay. So this kind of in this type of phenomenon, basically the space between the cells, this space is called as the paracellular spaces. Okay, this space is called as the paracellular space. Paracellular space, right? And the drug is moving in between the cells or the paracellular spaces. It is again an ATP independent process. It doesn't require it. Understood? Okay. Now we have different kind of transporters which are present, and this kind of movement basically is called the carrier mediated movement or carrier mediated transport, right? Carrier mediated transport, or this in this type of movement of the drug, if you require pumps, different kind of pumps. Okay, there are many pumps, and here, what is the basic funda? This will follow. I'm sure you must have heard about Michaelis-Menten equation. So this kind of transport will follow Michaelis-Menten equation. You must have read about Michaelis-Menten equation in your enzymes chapter in your pre-medical days, right? So this will follow Michaelis-Menten equation. Saturation can occur. Saturation is possible. Saturation is also possible, right? And here, what is happening basically? Let's say this is a cell, and here we have a transporter for the drug. This blue part, this one is a transporter. So the drug is basically going inside through the transporter, right? So this carrier mediated transport can also be two types. It can be facilitated or it can be active. Active transport or facilitated transport. So basically facilitated transport means there is no ATP use. It is going along the concentration gradient, but transporter is used. Okay, all the features of this simple diffusion, but transporter is used, right? So no ATP along the gradient, transporter is used. I'm writing T tick. So we have the example of a special transporter which is called the SLC transporter. SLC transporters, right? These are called as the SLC transporters. For example, you have GLUT4. I'm sure you must have heard about GLUT4, right? We'll learn more about glutes when you move to the endocrine chapter in the diabetes part, right? Active transport. Active transport means you all know ATP will be required against the gradient, and transporter obviously will be used, right? So we have something called as the ABC transporter. ABC transporter is basically an ATPase linked transporter. Basically, what is happening is that we have a cell like this, let's say, and this ABC transporter is basically like this, and it is a tail, and attached to this is a ATPase enzyme. ATPase enzyme is basically attached, right? And this type of transporter is called the ABC transporter, right? Okay, so what are the examples of active transport? We have something called as the OAT transporter, organic anion transporter. Okay, OAT, OAT, OAT. Don't say it OAT. Okay, just for your reference sake. Okay, so OAT transporter, and via this, two very important drugs go inside. One is a methyl dopa. One is your let's say P glycoprotein also, right? P glycoprotein. Talking about P glycoprotein, I get reminded of another transporter which is called the PGP transporter. Okay, these are a bit advanced concepts. Just try to understand. Okay, if you have a good understanding, then it will be very easy for you. PGP transporters. So PGP stands for P glycoprotein. It is basically an efflux pump. Efflux pump. I'm sure you must have heard about influx and efflux. So this is basically excreting the drug out. Okay, it is a ATPase linked transporter again, and it is basically effluxing the drug out, right? So let's say what I'm saying. Just let me represent. Let's say this is a PGP transporter and an ATPase is attached to it. So this is the P glycoprotein transporter. Let's say this is a drug which came inside via this. The drug came inside, but this PGP transporter is basically effluxing the drug out, right? So, so the drug is basically effluxed, effluxing the drug. Understood? So this is called as an efflux transporter, efflux pump, or it is also known as a multi-drug resistant transporter, MDR transporter. A efflux pump or efflux transporter or MDP transporter, okay, MDR transporter. Okay. So basically, what is the effect on the drug? So the drug is basically having an increased excretion. So it is basically what is it is doing? It is increasing the excretion of the drug. It is increasing the absorption of the drug. Basically, it is increasing the bioavailability of the drug. Are you understanding? Right? So it is present in different organs. It is present in your GIT. It is present in your kidney, right? Liver also. Let's say liver also, and can you identify this? What is this? Barrier type of thing? Yes, blood-brain barrier. So it is present everywhere, right? Okay. So in on what drugs the P glycoprotein is basically active? What are the substrates? This concept is not an MB concept. This is not for your main board examinations. This is basically a concept for your PG examinations. This concept, right? So this is for PG. What is the substrates of P glycoprotein? On what it basically acts? So we have let's say four drugs over which it acts. Okay, you can remember by this LIDs, LIDS, LIDs. This is looking like a lid of a let's say bottle. Okay, so this is we had a bottle, and this is the lid of the bottle. So it is basically acting like a lid. So lids. Okay, lids stand for L stands for a drug which is given for diarrhea. That is a loperamide. I stands for itraconazole. Azoles will read about this now, right? D stands for digoxin. Digoxin is a very big topic in pharmacology, a very interesting topic in cardiac pharmacology. In the CVS chapter, we'll read about it. And sofosbuvir. Sofosbuvir is a drug which is given for your hepatitis C virus treatment, right? So these are the substrates of P glycoprotein, right? Okay. So what are the drugs which can induce P glycoprotein? Inducers of P glycoprotein. What are the inducers of P glycoprotein? So P glycoprotein is induced by two drugs RR. Just remember RR. Okay, RR means rifampicin and ritonavir. Rifampicin. Rifampicin is a drug used for TB, tuberculosis, and ritonavir. Ritonavir is a drug for HIV, right? It's for HIV. Understood? So rifampicin and ritonavir. These are the inducers. So whenever if you give rifampicin plus loperamide, okay, the loperamide will not so effect. Why? Because rifampicin will induce the PGP. Okay, I am saying what I am saying is, let's say you gave a patient rifampicin plus loperamide. So what is the P glycoprotein use? P glycoprotein is effluxing out, right? So rifampicin is the inducer. So it induces PGP. Induces PGP means PGP will work more. It will work more means it will efflux the drug out, efflux the drug out. So loperamide will be effluxed out, loperamide will be excreted, right? Loperamide will be excreted. So this will show failure. So rifampicin plus loperamide is contraindicated, right? Very conceptual. If you don't know about P glycoprotein, you can't explain this. If you know, you can explain. Okay. Many drugs are inhibitors of P glycoprotein itself. Inhibitors of PGP. So what are the drugs which can inhibit the P glycoprotein? So there is a mnemonic. BC Karvaya Q. Q for Q. VC means video call. Okay. So you're saying someone that why did you do that video call? Okay. VC Karvaya Q. So this is the mnemonic just for learning purpose. So V is your verapamil. These mnemonics are devised by me only for easy memorization, I can say. And it's better if you just know the drugs. Mnemonic is not important. The drugs are important. So you can make your own mnemonic or follow this or whatever, but this must be in your mind, right? Okay. Verapamil, which is a calcium channel blocker. We'll learn that in chapter. C stand for cyclosporin. Cyclosporin, which is an immunosuppressant. Okay. K stands for ketoconazole. Ketoconazole is basically, you must have used ketoconazole shampoo for dandruffs, and seborrheic keratitis is also used. Okay, we'll learn about it. A stands for amiodarone. You read about in CBS. R stands for a drug ritonavir. Okay, I'm sure you must have been surprised, right? So ritonavir can act both as a PGP inducer and a PGP inhibitor, right? Okay. V is just the variable, just two V's are repeated. Like A is again the repeat. Okay, V and A are the repeat terms. Okay, you can just write this in small letters. Why? And Q stands for quinidine. Understood? So this is the mnemonic. Okay, and this drugs you have to understand. And again, another drug is there, erythromycin, somewhat important. So you just remember like this: erythromycin, clarithromycin, all of these are there. Okay, we have something called as a selective PGP inhibitor. A selective PGP inhibitor. Okay, these drugs are inhibitors only. They're non-selective. Their work is different. But we have three drugs which are inhibiting the PGP selectively, right? So we have something called as selective PGP inhibitors. The drugs are quidars. Okay, quidar and is pudar. Okay, just a tongue twister type of thing. Josuquidar, tariquidar, and valspodar. Josuquidar, tariquidar, and valspodar. Okay, these three are the selective PGP inhibitors. Okay, they're basically chemosensitizer type of agents, right? Okay, so talking about this, we first talked about simple diffusion, right? Simple diffusion. So in simple diffusion, we have to understand another thing. That is the simple diffusion. The rate of diffusion is governed by something called the Fick's law. Fick's law. This Fick's law is important. So Fick's law states that the rate of diffusion, I'm writing RD, you all wear caps, right? Cap by T. So what is this cap? C stands for the concentration of the drug. A stands for the area of cell membrane. P stands for the permeability coefficient. And T stands for the thickness of cell memory. Thickness of the cell memory. Okay. So this is your Fick's law. So these things, I believe, you all understood, and these things are important from the view of pharmacology even. But these things, I'm sure you must have read in your lower classes as well. If you have read physiology well, I know this transporters and pumps. These are part of pharmacology, but this basic parts you have read in your physiology, right? Okay. So let's start with some of the other concepts. Okay, what is the basics of drug absorption? Okay, the core part of the drug absorption. So I'm going into the core parts. Then we'll move to the roots of drug absorption. And so these are the easy parts. So from here, pay attention because the examiner will try to confuse you here. Okay, these are the parts where most of the confusions occur. Why the drug is being absorbed in the alkaline medium? Why the drug is being absorbed in the acidic medium? Okay, basic things which you have to know and don't get confused in here. Okay, just pay full attention, and I'm sure you'll understand it how it happens. Okay, okay. Let's take the example of an acidic drug, right? You all know the pH scale, right? I'm sure you know the pH scale. Here, what is the range? Zero. Here zero. I'm writing zero here. Here 7. What if this is neutral? 7 is neutral, right? No doubts. Yeah. Okay. So basically, what trying to say is that the drug, if this is the pH scale, okay, this is the pH scale. As we move here, as we move in this side, okay, in this side, we get weekly. Here we are moving means the weekly basic drugs are being absorbed more and more, and here means weekly acidic drugs are being absorbed more and more. Okay, and in 7, the neutral, the drug is basically ionized. Okay, the weakly acidic drug, just try to understand. The weakly acidic drug, it gets ionized into weakly basic drugs if the medium pH is changing from 7 to 14 onwards. Okay, I'm telling you, let's say here we have a drug D, which is a weakly acidic drug. It is being ionized into a ionized. It is being ionized. Okay, it is being converting, or you can say ionized for basic uses, right? Into other drugs as it moves from this 0 to 40, as it moves in the basic medium. And then weakly basic drug is being ionized as it moves here in the acidic part. This is the basic concept. Okay, so weakly acidic drug, just pay very close attention to my statements. Let's say the drug is weakly acidic. So in basic media means the drug is weakly acidic. In basic media, it is basically what is happening. Ionization is happening. Okay. In basic media, it becomes water soluble. And the same weakly acidic drug in acidic media, it is not getting ionized, right? In acidic media, is it getting ionized? No, it becomes lipid soluble. Okay, this statement, did you understand it or not? This is the statement which you have to understand. Did you get it or not? Let me repeat it again. Okay, because this concept is very crucial for your understanding. The examiner will try to confuse you between acidic, basic, alkaline, water soluble, lipid soluble. Okay, okay. Now we are going into the same statement in a different approach. Okay, let me state my approach first. Whenever we say a drug is lipid soluble, 100% lipid soluble, we mean that the drug is 100% non-polar. We also mean that the drug is 100% non-ionic. And whenever I say that it is a 100% water soluble drug, this 100% non-ionic means, can it cross the cell membrane? Yes, it can cross the cell membrane. In contrast, when you say that a drug is 100% water soluble, we tell that the drug is 100% polar. We say that the drug is 100% ionic. We say that the drug cannot cross the cell membrane. Understood? But we don't have such ideal drugs. We have the drugs in between. And these drugs are called as weak ionic drug. And if they can cross the cell membrane or not is governed by something called as the pK value. pK value governs if they can cross the cell membrane or right. Sorry. Understood? Yes. And again, a concept that whenever I say that, there was a call. So I was telling that the pK value governs if the drug can cross the cell membrane or not. Okay. And whenever I say that a drug is being ionized, remember say that the drug is being ionized, it is basically meaning that the drug is becoming water soluble. Right? Drug is ionizing means it is becoming water soluble. Okay. Now the same concept which I was telling in this box, this one, let me state it again. I made you graph 0, 7, 14. I told you that let's take a weekly acidic drug. Let's take a weekly acidic drug. This weekly acidic drug, if you put it in this kind of membrane or a basic medium, this weakly acidic drug in basic medium will ionize. If this weakly acidic drug is put in acidic medium, it will not ionize. So in basic medium it ionizes, in acidic medium it doesn't ionize, right? So in basic medium it will become water soluble because I told you that ionization means water solubility, so it becomes water soluble, and in acidic medium it becomes lipid soluble, right? If it becomes water soluble, can it be excreted out easily? Yes, can be excreted easily. If it becomes lipid soluble, can it enter the cell easily? Yes, there is an increase in absorption. Understood? This was our case 1. We took the case of a weakly acidic drug. This approach is good, right? I'm sure you must have understood by this time. Let's take case 2. In second case, I'm telling that we are taking a weekly basic drug. So again, 0, 7, 14. Now I'm taking a weekly basic drug. I'm taking a weekly basic drug, right? And this weekly basic drug, if I'm putting it in acidic medium, in acidic medium, it is getting ionized. It is getting ionized means it is becoming water soluble, means there will be easy excretion of the drug, right? And if this weekly basic drug is being put in the basic medium itself, it will not ionize. If it doesn't ionize, there will be lipid solubility increase and there will be increased absorption. Easy concept. These two cases, if you understood a major concept of pharmacology. Congratulations. Right? Okay. So let's see an application. So you must be wondering that why I'm stressing on this parts. Why why we require this as a doctor, right? So let's take the case of an interesting case of a peptic ulcer or the gastric ulcers caused by aspirin, right? So you know that aspirin causes peptic ulcer. Why? Why it is causing? So aspirin is basically an acidic drug. Acidic drug. The pH is 3.5 or something. Aspirin is absorbed in which part? Stomach. Aspirin is absorbed in stomach. The pH of the stomach, 0 to 1, 0 to 1 something, very acidic, right? So here what is happening is that a acidic drug is being put in the acidic medium. Means the lipid solubility is increasing. Lipid solubility is increased. Means if we zoom into this part, there'll be a stomach cell, enterocyte, any stomach cell. Means the aspirin is going inside more and more. Means there is an increase in absorption. I told you that if an acidic drug is put in an acidic medium, it will not ionize. It will go more and more into the cell, right? It will go more and more into the cell, right? So there is an increased absorption. And due to this increased absorption, it will remain inside the cell. Okay, there will be ionic trapping, ion trapping, phenomenon of ion trapping, right? And this causes peptic ulcer. This causes peptic ulcer. Understood? Done. This is the concept of what why peptic ulcers are caused by aspirin. Okay. So most acidic drug is they get absorbed in the small intestine, having the basic pH. Okay, and most basic drugs get absorbed from the small intestine again. Okay, why? Because of increased surface area only. So this statement is true, right? So aspirin is basically a drug which is not absorbed normally in stomach. Okay, 80% of aspirin is absorbed in the small intestine, and 20% is absorbed in the stomach. And when it gets absorbed in the stomach, basically aspirin is a COX inhibitor. We'll learn about in detail later, right? 20% is absorbed in the stomach, and this is basically if it gets absorbed in the stomach, then this happens. Okay. Similarly, we have a basic drug like morphine, the opioids, morphine. So morphine is a drug which is absorbed 95% in small intestine, 95% small intestine, and over 5% in stomach. Okay, so acidic drug is basically absorbed more in stomach. Why? Because we know this acidic drug. If you put an acidic drug in acidic medium, it will get more absorbed. Can you relate from this? Yeah. Okay. So this is finished. Then we have something called as the Henderson-Hasselbalch equation here. Henderson-Hasselbalch equation. What is this? The Henderson-Hasselbalch equation states that the pH is basically pK plus log sorry log 10 non-ionic concentration by ionic concentration. By ionic concentration. Okay, how much is ionized by how much is non-ionized for weakly acidic drugs? And you can state it alternatively, pH equal to pK plus log of 10 ionic concentration by non-ionic concentration if it is a weakly basic drug. Okay, so this is the Henderson-Hasselbalch equation. If the non-ionic and the ionic concentration is again 50-50, okay, 50%, let's say 50%, then what will happen? Then the pH will be equal to pK, neutral, right? This is the basics of Henderson-Hasselbalch equation. Okay, so another statement which you can relate from mathematics, that change in pH of a medium by 1. If we change the pH of the medium by 1, the ionization will change by 50%. Sorry, 10%, what I'm saying. 10%. Okay. If the pH of a medium is changed by 1, the ionization changes 10%. Right? You can, if you know the values, log 10 base 10 is 1. Okay. Log 10 base 2 is basically 2. Okay. So here the ionization is changed. It was 10 here and now it is 100, right? So there is a 10% change. 10% change, that is the change of the medium by 1. Okay, so alternatively, you can state that change the pH of the medium by 1, ionization will change by 10%. Understood? Okay, let's take an example. Let's say we have the pH of the medium 3.5. Okay, in 3.5, the medium pH is 3.5. Okay, and the pK of aspirin, let's say we take the example of aspirin. Aspirin is 3.5 again. The aspirin pK I told you, the example 3.5. The pH of the medium is 3.5 means what is the non-ionic by ionic concentration? The non-ionic and ionic. I told you that whenever there is an pK, pK and pH are same, the non-ionic concentration is 50%, the ionic concentration will be again 50%. Right? You change it by 2.5. But how much it will change? It will change by 10%. Right? It will change by 10%. Okay. The pH is changed by 1. So the non-ionic concentration, what will be the non-ionic concentration now? 90%. 90%. Are you getting it? Are you getting it? By this will be the 10%. Understood? 1.5, 99%, 1%. Again, 0.5, 99.9%, and 0.1%. 10, 10, 10, 10. Can you get? Yeah. So that is a table. Again, some examiners love to ask you. Okay. I don't know why, but mathematics stuff only. Like nothing to do with that thing. Okay. So that finishes our parts, conceptual parts basically. Now we are left with something called as a route of drug administration. What are the routes, different routes in which the drugs are administered into the body, and by what routes they are getting inside the body and causing the effects. Right. Let's discuss about routes of drug administration. Right. In what routes you are administering the drugs and how they're exerting their effects. Right. Are they going to the systemic circulation? Are they going to the uh, not, they're not touching the systemic circulation. We have something called tropical drugs. Tropical drugs means I'm saying tropical, sorry. Topical drugs. Topical drugs means there's the skin applying drugs, the creams and lotions. They're not moving to the systemic circulation, they're not passing the heart. Right. And some drugs are systemically absorbed. They're going into the blood vessel, going to the heart and circulating throughout the body, right? Like that. Okay. So I'm telling you, we have a local route. If you have to classify, we have something called a local route. We have something called a systemic route. Local route, systemic route. Systemic route means they are moving via the veins and going to the heart and gold. Local route means you apply that, it works there, nothing else. Done. Okay. Now in local route we have three types. Either it can be a topical route, topical route. Either it goes into cavity. Okay, some drugs are given intra-articularly, intrathecally. Okay, inside the blood, intravesical, right? Some drugs are there. So it either it may move into the deeper tissue, either they may be intra-arterial. So move in the arteries. Okay, the drug you inject in the artery and it moves to the tissue locally. No such systemic circulation there. Right. So topical drugs means the drug is applied on the skin, either on the skin or the mucous membrane. Mucous membranes means some vaginal creams are there. Some drugs may be applied on the conjunctiva. Okay. Some for fundoscopy, some drugs are applied on the conjunctiva itself. Right. Some eye drops are there. These all are topical. Okay. So applied on skin or mucous membrane, no big deal, right? Deeper tissue means we have examples here. So some drugs are you can say articular, intra articular. Articular, joints. What are the drugs? Some injections for arthritis, rheumatoid arthritis. Uh, injections for rheumatoid arthritis. Okay. Some drugs are intravesical, means injected into the bladder. Two drugs are there: BCG vaccine, mitomycin. Some drugs are intravitreal. Vitreal, vitreous humor, right? Some drugs for CMV retinitis, basically. The drug example is ganciclovir for cytomegalovirus retinitis. This drug is used, okay, for the CMV retinitis, and this is given intravitreally, the eye injections. Very, it may be painful also. Some intrapleural drugs are there. Intrapleural and the pleural space, like right. We have doxycycline. Doxycycline is given a variety of routes. Orally, doxycycline is a very effective drug used in the routine medical practice. Okay, some drugs are given intrathecally. Okay, in the subarachnoid space. Intrathecal in SAH. SAH means subarachnoid space. So we have two M's. Okay, MM. Where was the what was the mnemonic in RR? RR. I told you today. RR means, do tell me. Giving you a hint, it is related somewhat to PGP. Yes. Okay. Midazolam and methotrexate. Midazolam is basically an analgesic drug, and methotrexate is anti-cancer drug used in leukemia also. Okay, many other uses there. So these are the examples where drugs are injected locally into the deeper tissues. Right? Done. Okay. Intra-arterial means the drug is injected into an artery. You get the drug into an artery. This goes to the tissue. Local action, no such things. Nowadays, not much used. Like in movies, you must have seen carotid injections. Okay, carotid injections, right? So that finishes our intra-articular. I told you, yeah, injection for rheumatoid arthritis or the corticosteroids, prednisone and all. Okay, okay, that is done. Our local route is done. Now let's move to the systemic route. Systemic route. In systemic route, either it may be an enteral route or it may be parenteral route. Enteral route, parenteral. Enteral and parenteral. Parenteral means passing the GIT. Okay, you are not. It's not going through the GIT. It is directly going, okay, to the tissue, into the systemic circulation, bypassing the GIT. Right. So parenteral means there is a bypass of the GIT. In enteral route, again we have three basic things. Three routes: oral route, sublingual route, rectal route. Oral, sublingual, rectal. Parenteral routes, we have two types: injectables and non-injectables. Injectables, non-injectables. Injectables, again, we can have variety of injections. We'll talk about it in detail. Okay. Oral route. Oral route means basically we are going through the GIT, and in oral route, what is happening? The advantage is that the oral route is the commonest route of drugs. You must have eaten tablets, pills, syrups, cup syrups, and tinctures, lentils. Okay, all this. So it is the commonest, cheapest, convenient for kids and all, right? What is the disadvantage? What is the disadvantage? In case of emergency, you can't use it. Can you use it oral route in emergency? Will you give a tablet to a patient who is in coma? Say no. If a patient is vomiting, can you use oral route? No. If a patient is unconscious, can't use. If a patient is being is requiring something uh, costly medications like monoclonal antibodies, right? Some costly medications are there like monoclonal antibodies. Okay, so if in oral route, just remember that you can't give some medications which are proteins or peptides. These proteins or peptides you can't give by oral route. Okay. How can you identify proteins and peptides? Let's see. Not given orally. These are not given orally. Okay. So any drug which is ending with intide is ma'am. Okay. Basically, any drug which is ending with intide is ma'am. You can't give orally. Intide is ma'am. What are the examples? Insulin, calcitonin, insulin. What is the example of tide? Semaglutide, teglutide, teriparatide, octreotide. Many examples are there. Octreotide, semaglutide. Any others? Is what are the examples? Rasburicase, asparaginase, or the enzymes. What is MAB? MAB means all the monoclonal antibodies. MAB stands for monoclonal antibodies, like eculizumab, adalimumab, aducanumab, benralizumab, many other. Okay, I can list just 10, 15 monoclonal antibodies. Huh? Understood? You can't give any of these drugs orally. Okay. Just remember that in oral route, the drug undergoes first pass metabolism. The drug undergoes first pass metabolism. Drug undergoes FPM in oral route. Right. So let's say this is the stomach. You gave someone 100 milligram dose. 100 milligram dose. This drug goes to the portal vein. This is the portal vein. Via portal vein, it reaches the liver. Reaches the liver. Liver will degrade 60 milligram. Let's say liver degrades 60 milligram. Sorry. Liver sends it via IVC. IVC means inferior vena cava. If it is not visible, I'm writing this. IVC, inferior vena cava. From inferior vena cava, it moves to heart. Heart. So, what is the concentration that is achieved on heart? How much concentration of blood drug is basically? And this 40 milligram drug goes to the body. Understood? So this is called as the first pass metabolism. Okay. So this degradation of the drug by liver is called the first pass metabolism. This 40 milligram dose, this 40 milligram drug basically is called as the bioavailability, the available drug for the body. Okay. And this first pass metabolism is calculated by something called as a FPM, is calculated by something called as an hepatic clearance. Hepatic clearance. Hepatic clearance. Understood? So let's say we have 100 milligram. I'm writing concentration 1. With 40 milligram concentration 2. So C hepatic clearance will be HC hepatic clearance C1 minus C2 by C1 into hepatic blood flow into hepatic blood flow. This is the hepatic clearance, right? And this parameter is something known as the extraction ratio. This is called the extraction ratio. Okay. If a drug has very fast, very high first pass metabolism, it is not given orally. Okay, or it is given in high oral dose. Okay, some drugs are not given orally because they have very high fast pass metabolism. What are the drugs having very high FPM? What are the drugs? You can remember self. What is the meaning of the self? They're selfish. Okay, they're selfish drugs or self. Steroids. Steroids means all the steroids like hydrocortisone, aldosterone, testosterone, estrogen, all of this. Epinephrine, norepinephrine, okay, lignocaine, and fentanyl, fentanyl and all. These are not given orally due to very high FPM or fast pass metabolism. Some drugs have high, good, very significant fast pass metabolism, but they're used orally. Okay, some drugs are there which have very high, fast pass metabolism, but they're used. Okay, so what is the mnemonic for that? So the mnemonic will be PM VP Singh. PM VP Singh. Okay. So P stands for propranolol. P stands for propranolol. M stands for morphine. You must have heard about this drug again, verapamil. I told you, and pethidine. Okay. PM VP is done. S for your salbutamol. I for your imipramine. Okay, and nitroglycerin, salbutamol, imipramine, NG for nitroglycerin, and H just to make it complete high FPM, but given in high oral dose. High, high. Okay, so that completes our high BPM, high FPM dose, right? Okay. So that was our story up to now. In the next class onwards, we'll start about other parts of drug absorption. Okay. Let me finish the two smaller ones either. Okay. So how to avoid fast pass metabolism? How to avoid FPM? You give a drug if the drug is given below the tongue. If drug is given below the tongue, there is a branch of SVC below the tongue. This one, if you just flip your tongue backwards and see, if a drug is given below the tongue, it can be absorbed without. It can be possible that it is going to the SVC directly, bypassing it. Right? Use sublingual route. So let's say here is our tongue. If a drug is given below it, beneath the tongue, it will go to the SVC, it will go to the heart. There'll be no this kind of story. There'll be no liver role. Liver will be not be there. So a fast pass metabolism will not be there. Right? And what are the drugs which you have to remember? You can remember MN. MN. M is for misoprostol. Misoprostol is basically used for inducing abortion, an abortion, and N stands for nitroglycerin. Nitroglycerin, or you can use nicotine also. Nicotine. Okay, nicotine is for addiction, de-addiction. Nitroglycerin is for angina and others, CBS problems, right? Another route which we learned here, just I'm sure must be saturated by now. So oral is done, sublingual is done. Now we have to discuss rectal route, and this is our last topic. So bear with me some few more minutes. Okay, write it below. Rectal route. So this rectal route basically either you can use two type of veins here. Either you can use an internal hemorrhageal vein, or you can use an external hemorrhageal vein. Okay. If you use the internal hemorrhageal vein, then it will not bypass the fast pass metabolism. Okay. But if you use your external hemorrhoidal vein, okay, external hemorrhoidal vein, it will bypass the first pass metabolism. So basically, what is happening is that here you have a liver, there is the portal vein. You can inject the drug here. Okay, it will move a branch of sorry. So this is our internal hemorrhoidal vein. So the drug will move by the internal hemorrhoidal vein. Okay, it will not bypass your FPM. So FPM will happen here, and the drug will be delivered in the rectum. Right. From the rectum, it is basically going not delivered to the rectum. From the rectum is basically it's going in retrograde manner, right? Like this. It will have FPM and go to the body. But again, another vein is draining here. Another alternative, I can say, is this one. This is external. External hemorrhoidal vein. External hemorrhoidal vein is basically going directly to the IVC. It is draining to the inferior vena cava. And from the inferior vena cava, it directly goes to the heart, right? So there is no role of liver. So FPM is absent here. Okay. So this is our rectal route. So you can use either internal one or the external one. Understood? So what are the examples? Just two examples. One is the rectal diazepam. Rectal diazepam. Rectal diazepam is the drug of choice for you can say febrile seizures in children. Drug of choice for febrile seizures in children, right? And we can also give another drug you can remember, rectal glycerol. Rectal glycerol. Rectal glycerol. Rectal glycerol is used in the. It is an osmotically active drug used for the treatment of NAG. NAG means narrow angle glaucoma. Okay, so rectal diazepam and rectal glycerol are the two drugs which are given by this rectal route. So that completes our things which we have to which I have done today. So this is our absorption one, the first lecture in general pharmacology, and we discussed up to the enteral route. Uh, from the next day, tomorrow or some other day, we'll cover the parenteral route, right? Intravenous, you can say osseous, intraosseous route, intramuscular injections, what are the subcutaneous injections, on what degree we'll inject it, what about the transdermal patches, okay, which patch is indicated for which, like we use must have heard about nicotine patches, right? Nicotine patches for smoking cessation, okay, and we use some estrogen patches too for hormonal replacement therapy, okay, rotigotine patches which is in Parkinson's disease, used in Parkinson's, right? And we'll discuss about inhalational route, like what are the gases and dry powders. Then we'll move to a concept called bioavailability, and winding out the chapter bioavailability and bioequivalence. Then we are done with the absorption, right? This is the large part, and after that we'll discuss metabolism and distribution. Next session onwards. So that was for today. If you have any doubts, you can contact me. Do give your feedbacks in the comment section. Meet you in next lecture. Bye bye. Good night.